Dr. Raul Gonzalez Fregoso. I am vascular surgeon and angiologist. I work at Luca, Centro, Vascular, Querétaro, Mexico. And I apologize in advance for my English grammar, which is not really sophisticated. So I'm going to start with my work. It's named Angiotensin II receptor blockers as a risk factor for skin ulcers. Well, what is the background? I met in March 2013 a female 60 years old with systemic arterial hypertension and morbid obesity, and of course with a big painful skin ulcer in the left leg. She came with a diagnosis of leukocytoclastic vasculitis done by a pathologist. I decided to repeat that study, and my pathologist conclude the same thing. So I sent the patient to the rheumatologist, and the rheumatologist started with conventional treatment like steroids, immunosuppressors, etc. And the ulcer started slowly to heal. Everything was fine until July 2015. I put this picture because I was relaxing in holidays in a Caribbean beach in Mexico, and suddenly I received a calling from the patient's son. And he told me that his mother was screaming in pain with red blisters in his right leg. I want a right leg. Why? Because the problem was in the left leg. So I asked him, send me some pictures. So I could believe, but the problem, yes, indeed, was in the right leg. You can see the original white bandage in the left leg. And as you see, the patient start with red wine colored blisters, very painful. And curiously, the patient was taking the rheumatologic treatment in that moment. So it's stranger. When I came back, I could verify the skin damage. A lot of necrosis, very big blisters, and I had to remove about 3% of the skin in the leg. A puzzle, I asked to the son, what happened? If there had been some change in the routine, and the son just explained that the cardiologist had changed the losartan to telmisartan because the telmisartan was stronger to control the blood pressure than losartan. So I asked myself, could the ARB be the cause of skin damage? So I start to ask about that, and I start to check in my records of my patient, looking for some patient who had an ulcer with a clear diagnosis. And guess what? I found some patient with those characteristics, patient with non-vascular ulcers, I mean no arterial or venous ulcers, with superficial ulcers, and they were taking losartan, telmisartan, candesartan, or irbesartan. The ulcers always involves the skin and subcutaneous tissue. Painful with no specific location, could be in the foot, could be in the ankle, could be the shin, could be the calf, but always under the knee. The ulcers were very painful, like ischemic pain. I mean, the pain increased with resting when the patient raises the leg when he sleeps. So it's very characteristic. As I said before, always compromising the skin and subcutaneous tissue, but with necrosis or inflammatory edges. This is a similar case as the first case with red wine colored blisters, but less aggressive. Could have the patient several ulcers in the same leg. The pulsus, the arterial tree was fine, curiously. This patient spent 6 years trying to find good treatment, but as you see, he couldn't get good treatment or even good diagnosis. And as you see, the ulcers always involves the under the knee in the leg. Could be bilateral. If you see, we have a red edge inflammatory component. But the worst thing is when the patient decides take alternative medicine. In this case, this patient received herb infusion over the wound, and of course, the ulcer is complicated. Same case, other patient with herb infusion over the wound. Or this patient that received ozone therapy. I don't know. The patient could not explain to me what was the technique, but as you see, it's very complicated and with infection as well. So, what was the next step? I thought I must ask physician to switch from antihypertensive ARB to non-ARB, of course. But the next problem was the reluctance of physician to change the antihypertensive for a non-ARB. Why I must change this medicine if your blood pressure is controlled and there's no information about this problem? So I could find out, and I could understand to those physicians because there's no information. So I start to investigate with drug-induced vasculitis. And drug-induced vasculitis, you can see that the main drug was implicated in, say, thiazide, aspirin, allopurinol, penicillin, cephalosporin, propyltracidine, etc. And most cutaneous vasculitis induced by drugs are leukocytoclastic on in morphology, but never say that antihypertensives are involved, except thiazides. So well, I wonder what is the morphology of leukocytoclastic vasculitis. So I review in rheumatologic works, and the leukocytoclastic vasculitis presents with papules, they are itchy with a little pain, something like that, but never like skin ulcers. So the leukocytoclastic vasculitis is on a specific diagnosis. So I changed my route. I start to look for cutaneous adverse drug reaction reported only with antihypertensives. I found angioedema, photosensitivity, pemphigus, dry mouth, alopecia, etc., but never skin ulcers. So I went deeper, and I looked for those same adverse effects in agents acting on the renin-angiotensin system. I could find exanteme urticaria and some serious problem. What were some serious? By losartan, angioedema, and for captopril hydrochlorothiazide lichenoid dermatitis, but no skin ulcers. Looking for keywords like ACE inhibitors, angiotensin, adverse events, angioedema, and losartan, I found this article done by Stekellins. It's a researcher that is expert in renin-angiotensin system. And the same, she could find just angioedema, pruritus, bullous eruption, urticaria, etc., but no skin ulcers either. So my next challenge was convince doctors to switch from RV antihypertensive to non-RV. So I start a protocol by my own. So my work was case and control trial with an universe of 6,799 patients reviewed in the first visit in a period of 15 years. The patient with ulcer of vascular origin, like arterial, venous origin, with a history of autoimmune pathologies with cancer or the cubitus ulcer were not included, of course. Well, I got a total of 69 patients with lesions were included. With average age of 70.3 years. The predominant location of the ulcers, as I said before, was on the legs. The presentation of pain was similar to that of critical ischemia. I repeat, very, very aggressive pain, several times screaming in pain. So in the results, we could not find significant results between risk factors like chronic disease or drug addiction, diabetes mellitus, high blood pressure, heart failure, arrhythmias, lipidemias, etc., smoking, alcohol use. But when I compare the different treatments, we can find in ARB's group a significant difference between concerning group and control group. So finally, I could prove the cause of some skin ulcers with no explanation. The possible etiologies could be first, like another medicines that provokes skin ulcers that is demonstrated is secondary vascular inflammatory processes in small vessel vasculitis secondary to autoimmune complexes or accumulation of bradykinin. It's not well known, this mechanism, but this is something about AT1 receptors, angiotensin II receptors in the skin, that when those receptors are blocked by that medicine, the bradykinin is tends to accumulate. Well, but the renin-angiotensin system not only acts to increase blood pressure in the conventional route, renin-angiotensin that always, of course, you know, but also acts in the intestinal physiology, acting in motility, in absorption, and in intestinal disease like inflammatory disease or cancer disease. And guess what? The renin-angiotensin system acts in the skin regeneration too. The same researcher, Stekellins, described in rats in 1995 that other receptors in the skin, A22, acts in the skin regenerations, and she done another protocol in 2005, and she could prove that in this system acts in human too. So we can explain that sometimes, maybe with mild trauma in the skin could not regenerate because we are using this medicine that blockade the skin regeneration system. So our conclusions are ARB drugs are a risk factor for the presence of cutaneous ulcers. Although it is a rare entity, just 1% mild lesion. This pathology should be considered in a skin ulcer with no known etiology and with the simultaneous ingestion of ARB type medicines. This picture is not the objective of this presentation, but I want to show this 96 years old female that came with this problem, and after we withdraw the ARBs and after a lot of care and a lot of months, she could heal her wounds. This is the published article. You can get free online in Revista Mexicana de Angiología or in ResearchGate. Thank you very much.